severely complete fractures, about 15% of cases require treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing. Unlike conservative management, it provides stable fixation and early mobilization and reduce the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, or were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out the state side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement. And the jet type of condition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures, either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine on a affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed lip. The incision is small incision and a transverse or longitudinal incision about 1 to 1.5 centimeter, just lighter to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial still. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15D1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15D1 fracture treated by titanium elastic nailing. Yet another case of 15D1 fracture treated by titanium elastic nailing. These are the 15D2 fracture. This is 15D3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see that 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see. So the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clavicle fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. The registered teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is that tense nailing is unlike conservative management. It provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out the stage head was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement. And the jet type of condition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and screw. So these are already explained. The simple fracture were taken into consideration. Displaced simple fractures either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine on the affected lip elevated and the arm are hanging outside the table so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed midge. The incision is small incision and a transverse or longitudinal incision about 1 to 1.5 centimeters. Just lightened to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very crucial. One should take its own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate course of pain management and immobilization, at the 2 weeks we do did suture removal at 6 weeks, radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required, the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bypass, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nerve, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nerve. Yet another case of 15B1 fracture treated by titanium elastic nerve. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nerve. Ideally, it should be treated by open reduction and internal fixation, but we did dense nailing, and you can see that 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see. So the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture. The take-home message is dense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. The registered teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of dense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that in the dense nailing, unlike conservative management, it provides stable fixation and
I have been making videos on YouTube for months, but I am not reaching 1,000 subscribers, not 4,000 watch hours.
Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence is less invasive, resulting in smaller incision. After the study between March 2020 to March 2025, on 25 cases of the displaced fracture of the clinical, the age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nerve. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of comminuted fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short of the fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is a very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up with the 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the 1ST surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did, the 15B1 fracture again treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with a plate and a screw. But we did titanium elastic nailing in this case also. And you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish the this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results. The minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
माइक्रोसॉफ्ट एक्सेल जिसमें आज 1 लाख से भी ज्यादा जॉब ओपनिंग्स हैं और मैक्सिमम जो जॉब्स हैं वो 10 से 15 लाख और 15 से 20 लाख के पैकेज पे हैं। आप अभी naukri.com पे जाओ, MS एक्सेल जॉब इन इंडिया सर्च मारो।
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सिलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सीआर के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सीआर को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल, और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। झूठ बोल के तरह कहता कि 4,000 से ज्यादा नहीं खोल सकते। 5,000 हम ही करा इधर थी बहुत 1 लाख के नौकरी करोड़ के ये बहुत 80 का मेरा है तो हम आपसे दे रहे छोटा छोटा सब छोड़ दे रहा तो गाड़ी हो गई हमने जो बात करता था कैसे ले इंजीनियरों को भाइयों को और कितना उनका पर यूज चालू होता इंजीनियर का एक बार यूज हो सकता है ठीक है हमारी बुराई वो एक बार यूज करी बेटा से कराई भाई तुम बताओ ना तुम आइडिया दो तो हम बड़ा कराते हैं अरे किया से पूछा था नहीं कहीं सरवा जाना शुरू कर फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टीरियर जो होल है उसको गोल किया गया है। इस तरह से सीआर को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टीरियर स्क्रू को डाल दिया गया है जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है, इस तरह से सीआर को एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में, और ये फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला। Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground.
क्या आप एक सक्सेसफुल रेकी हीलर बनना चाहते हैं? सिर्फ 3 घंटे में आप बन सकते हैं एक कॉन्फिडेंट।
Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence is less invasive, resulting in smaller incision. 17 years old man, the road traffic accident was the mechanism of injury. Clinical present. Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This blood dissection of the tissues I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am hammering the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture, the correct उगे तो बा प्लेट बा, सॉकेट बा, स्विच बा, इंडिकेटर बा, रेगुलेटर बा। हाँ तो बाद में भेजवा देती है, और का वो तो भेजने में क्या दिक्कत है। लेकिन हमरा लोकल उहे खाली आ उ नोटिफिकेशन में उहे आवत रहे। दे 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 रेगुलेटर बा, फेन आउट सीट बा, उहे सीटे बाटे वो बैठावेलन सर बोर्डवा जौन। और उसके बाद कादू सलंग की कादू लिखा है, टेप, कौनसी फ्लाई, एमसीबी, जैम्बर, माउस की कादू लिख ले बा, लॉक सीट, मशीन स्क्रूप, कादू मशीन स्क्रूप लिखा है। सब ओकरे चीज बा। Converting in the CR picture, the correct entry point I am introducing by a screen movement of the CR, and you can see that this is the every view it has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior two-thirds, at the junction of the anterior two-thirds and posterior one-third of the dental trochanter. So, after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we removed this bone out, and then after reduction of the fracture, with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ream the medullary canal with the help of 9 millimeter ream of, and and it is being rimmed with 9 millimeter rim, hand rim. And it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing rimming with a 10 millimeter rimmer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in empty view, and also in lateral view. This is the oblique view. And after performing in the CR, in both views, we did rimming up to the lower end of the femur, and finally we rimmed this fracture with the help of power rim of 11 millimeter. Because the patient is old one, so rimming is easy. It is just to measure the size of the intermedullary canal, the diameter of the intermedullary canal, so what size of the nail should be introduced so that it can fit in the intermedullary canal. The fitting nail can be introduced. So this is the purpose of rimming, because the patient is old one, osteoporotic. Throughout the nailing process, rimming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been rimmed up to the upper end of the patella, as you can see in the CR picture. You can see in the CR picture. It is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter good position. The fracture is reduced in both views, in the oblique view and empty view and lateral view. before proximal locking, and now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside, is confirmed in the altitude, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was nearly off. So it was accepted, and you can see that both in the anterior and lateral view, the both proximal as well as the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound so that all the... Now I am closing the wound after forceful wash of the wound. Now the wound has been closed. And my surgery is over. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for fracture sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on the whole a successful and well-executed surgery. Thank you. Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today I will give a demo of PFN surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture, and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric unstable type. And this is the post-operative X-ray of the same patient, and now I am going to start my surgery. The skin incision, before the skin incision, I will drop a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry, it should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in epi view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone owl at the correct point selected, and then I am confirming this whether this bone owl is entering at correct selected point or not in CR picture. So I am introducing the owl in correct position after confirming the entry point in CR picture, both in epi and lateral view. So this is the epi view. It is entering in proper selected position, and this is inside the intramedullary bone owl for 2 centimeters to introduce the guide wire, the depression of the laterally in the owl. So it is inside the intramedullary canal, well placed in epi view. And now I will remove the owl of the medullary canal. In the osteoporotic patient, the reading is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the EFN. I am reading with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reading this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been named the spiral blade can be introduced in central position in epi view. And now I am giving an incision for introduction of the spiral blade and position in both epi and lateral view. You can see in the picture, it is in very good place. It is central in epi view and central in lateral view also. So I am doing movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both epi and lateral view, and then my assistant is attaching the arm for digital locking. I am hammering this hard and stout guide wire in the lateral cortex. And after confirming it, see our picture. The final tightening is being done now. It has been tightened. I will assist the skin, assistant, my supporting staff. I think this is the well-executed strategy for a old osteoporotic patient, for unstable type of interconnected fracture. We can make this patient mobile from second post-operative pain, which is usually required. Although this was not a very distressed fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you. Thank you, everyone.
Hello friends, I am Dr. RCT Thakur, orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Suprapatellar nailing becoming popular choice for treating metaphyseal fractures. It is highly specialized surgery and requires very highly specialized instruments, sets and implants that tends to be very costly. Dr. Thakur innovative technique of suprapatellar nailing of tibia delivers 100% satisfactory union of fracture in safe and cost-effective way. No special instrument or jig are required. A protective slip and a dropper can be used from PFN A to Z, and color-coded infrapatellar tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 20 was fixed by Dr. Thakur innovative technique of suprapatellar nailing of tibia. This is the flow diagram how Dr. Thakur innovative technique of suprapatellar nailing of tibia done. It is done in same appropriate size over the color-coded tibial nail extractor done. Introduction of appropriate nail size over the guide wire done in proper position with the help of color-coded tibial nail extractor. Locking both proximal and distal done by freehand technique. No hard guide wire in the retropatellar space in AP and lateral view. Passage of primer over the guide wire after percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry in distal fragment in lateral view, and then both locking screw introduced in proximal fragment. In AP and lateral view, all the three screws introduced in distal fragment by freehand technique. This is the clinical picture. Proximal locking done by freehand technique. Post-operative follow-up steps. First post 8 weeks after surgery with fracture healing time was 12 weeks. Average hospital stay was 10 to 12. Follow-up, 21 cases found excellent and 4 good results. In none of the patient, removal of nail was done for any cause. Tibial fractures AP and lateral view post-op, and this is the clinical pictures, 3 weeks follow-up. Okay. Fourth case, pre-op X-ray, upper metaphyseal fracture of tibia, and this is the post-op X-ray of upper third fracture of metaphyseal tibia. This is fifth case, the lower third, very, very low fracture of tibia, and this is the post-op AP and lateral view. This is the clinical picture 3 weeks after the surgery. Duration of this surgery, the number of cases included in this study was small. The study was not comparative with the standard technique. The status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger population and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. Finally, friends, this innovative technique is very, very cost effective. In fact, no cost is incurred for this suprapatellar technique. Whereas the standard instrument sets are very, very costly. This technique can be adopted in smaller and medium class orthopedic hospital. If the only disadvantage of this technique is the slightly more radiation occurs because the locking both proximal and distal are done with freehand technique. But this can be lessened by gaining more and more experience in freehand technique for locking proximal and distal tibia. Thank you. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number 2 is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. It is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spinal groove. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remote, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the 2 myths which is associated with interlocking nailing of humerus, and other 2 controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are 3 positions. Number 1, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But
the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the dill bit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry fold, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nail. Number 3 controversy is because it is non-weight bearing bone, so one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, other start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by 2 screw proximal and 2 screw distal. So, friends, these are the advantages of locking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
If you are running a business where you are the one who's managing operations, sales, marketing, finances, hiring, and everything else, then let me tell you something. You're not really running a business. Your business is making you run because you've set yourself in a trap called the trap of self-employment. Self-employment is a
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं, उनके दाहिने कूल्हे लिया है पिक्चर, जिन्हें टोटल कूल्हा उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में, और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर कूल्हा को बदला गया है, उसको पैर रखना, उस पैर को रखना है, उसके बाद अच्छे पैर को रखना है, और चढ़ते समय पहले करते समय पहले जो बदला गया है उसको रखना है। मूवमेंट अपनी ज्वाइंट आप देख सकते हैं और लो चेयर पर भी आराम से बैठ जा रहे हैं। चल पा रहे हैं।
Design the perfect voice for your brand with 11 Labs. Change the way you record podcasts, voiceovers, and
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की
किया गया है, जो और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः इससे छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है, जिसमें मेरा नाम आया है।
The supine position of the patient with a bump in the interscapular space, in which position I do interlocking nailing of humerus. With the traction only, with the assistant, both sides, the traction is given and externally rotation, external